Welcome back to a ACRO CURiE author interview. Looking forward to talking with Dr. Tony Song today and reviewing a little more in depth his article, Achieving Equity in Transportation for Radiation Therapy. And Dr. Song and I have chatted in advance, and we're going to go by first names during our interview and informational session for this article. And so, Tony, I always like to get started with knowing kind of what drew you into radiation oncology. So give us a little background on yourself.
Sure. Yeah, I think probably a little bit different than, I guess, I'm a fourth year resident, different than most residents. And I think in college and medical school, I actually maybe shied away from cancer research. Ultimately was more interested in cellular neuroscience. So after medical school, I actually matched neurosurgery. So was doing a neurosurgery residency for some time. And at one point I was thinking about making a change and had really interacted with some of the radiation oncology residents here at my home institution, and was sort of talking to the PD about what exactly radiation oncology was all about. I think at that point I was interested in maybe radiology and radiation therapy. I think one of the most interesting things was being consulted on a patient and being told that, hey, the patient's not in the room, they're going for radiation simulation. I had no idea what that was and found myself actually for the first time in the cancer center in the simulation CT, waiting for the patient to talk to the patient. So after that, I got a little bit more interested, talked to the residents about radiation oncology, and sort of, things that drew me in were sort of the use, the fact that it's a highly specialized field. And just like neurosurgery or surgery in general, very reliant on imaging, and then also, interpreting, using imaging, yourself. So that was one of the things that drew me in. Also, the sort of methodical way that radiation oncologists approach radiation planning, much like a surgeon would approach a surgery, was another one of those things that sort of clicked and carried over from my surgical experience. Unfortunately, after some time of talking with the program director here, a spot opened up, and I thought, after months of deliberation, I decided to make the jump.
Yeah, that gives you a really unique perspective. I think there's such advantages to be understanding the surgical process and the surgical techniques, and it certainly helps with our radiation planning. I feel like the more knowledge you have, and I mean, we're just a little bit different lifestyle. I can't say better or not better. I'll leave that to our audience, but
Yeah, it was definitely a different world stepping into the cancer center from the hospital, for sure.
Well, we're very glad to have you and that you made the transition. So give us a little background on why this particular topic interested you, and what was the avenue that made it possible for you to do this research?
Yeah, so initially this came out of actually talking with my mentor, Dr. Sura. We were kind of discussing topics outside of radiation oncology. We were talking about radiation oncology reimbursement, which is a topic that's not often discussed or taught in residency. So this was one of those topics that we were just having discussion with in the resident room, sort of informally. And the ROCR, the Radiation Oncology Case Rate Program that's been proposed, came up. And then I started looking at some of the literature behind it, the ROCR website, and both Dr. Sur and I kind of stumbled upon this sort of heart adjustment, and that made us think to ourselves, this seems like an interesting thing that they've added to the case rate program. what are we doing for our patients here? Transportation, we serve a relatively large area, and we do have patients that drive sometimes an hour or more, 2 hours, to come to our treatments. So that sort of just sparked the question, what are we doing, at our own institution to help patients who have need in terms of transportation getting to radiation therapy? And that, at that point, we thought we would at least start with a smaller pilot study, which is what this article, includes, a survey study where we could actually use some, collect some data from the patients themselves, ask them about how financially taxing, paying for transportation is, and then sort of got into the more background of how these things are reimbursed.
And prior to doing this kind of study, do you feel like you were having patients talk to you about that cost burden? I have seen that sometimes that patients talk less about it, but if you ask them, if they're aware enough to ask, they confide that it is an issue. So I was curious, like prior, your pre-hypothesis, pre-experience.
Yeah, so it does come up. I think, medical costs in general do come up in a lot of our consults. When patients come see us, often we hear the question of like, will this be covered? Even at, initial consult where they're just being told their diagnosis or told their treatment options, I think in everyone's mind these days is this going to cost me an arm and leg to go through treatment? Obviously for a very serious situation, which can be, treatments can be costly. So overall treatment costs do come up a lot. And then we do have patients who say, especially the patients who are from far away, ask about, when we say, treatment's going to be 6 weeks of daily treatment, that's when it starts to come up, when they understand how taxing it is to come daily for these treatments. So we do have patients inquire into it. And, as I found out through doing research and reading about this, even at our own institution, there's not often a systematic like screening or survey for these patients. And so many of them don't know what's available to them, or many patients don't know when, to ask for help. So that was one of the, things that came up in clinic.
Oh, that's great. So give us kind of an overview of your article methods and then the findings.
Yeah, so we did a smaller pilot study, improved by our RRB, where we mostly used the functional assessment of chronic illness cost measure. So the FACIT, is a larger set of surveys, and we specifically focused on the cost measure and then collected some other patient data, including, distance to treatment and the mode of transportation that patients use, and actually cost of gas during that time. And we had, help from our nurses to screen patients and our on-treatment patients who were interested in the survey and who were interested in learning more about what options we had here at the Cancer Center. So we were able to do this over a couple of months, collect, the surveys, and then look at, how these patients responded to the survey. We were mostly interested in how transportation and the associated cost of transportation for most of our patients most of them were driving themselves, how that affected their feeling of financial toxicity, of their abilities to pay their bills and things like that. So we tried to see if there was any correlation between costs. And this was a time actually sort of at the end of COVID where gas prices were actually quite high still. And we sort of just looked at that trend. And one of the things that we found is when gas prices rose over $4 a gallon, and for these patients who were coming from far away, that really affected their ability to actually, feel like they could consistently come to treatment, that they still felt financially secure. And when costs were high, they didn't feel financially secure. They felt this was a big financial burden to them. And so after learning about this, we started to after we were, and as we were running this process, this survey, we were looking into kind of how other centers may have tackled this issue, and the data on this, other studies that have looked at the issue of transportation in oncology care in general.
And for your kind of validated facet, is that a free tool that's available to anybody, or did the institution have some kind of cost sharing for that?
Yeah, I believe our department, when we proposed this project, set aside some funds to license that facet cost measure. So we did have to license that study.
Okay.
Yeah.
And of the questions kind of in there, do you feel like there's, kind of when we have these like long questionnaires, sometimes they're not as clinically practical, patients would be filling out if we asked for about every detail, hundreds of pages. Are there key questions that you feel like might be like, ooh, if I was going to ask 3, these are like kind of some highlights?
Yeah, the facet cost measure is I would say a pretty generalized cost like a survey. For our purposes, it didn't necessarily specifically touch on transportation per se, but overall feelings of financial toxicity, how much do treatment costs affect into that into their financial wellness. And so we sort of edited part of the facet questions and added to them. Some of the more, I think, more salient ones for us were, how have out-of-pocket medical expenses affected your financial wellness? Do you feel like, the cost of transportation to your treatments significantly affect your ability to meet your medical bills and meet all, continue to be financially secure. And then other questions that we added ourselves that, again, FACET was a little bit more generalized, were things like, are you aware of cost of transportation cost assistance options at your treatment facility?
Right. Yeah. And if you were to kind of give us, now that you've done this research, kind of your post-research evaluation, tell me kind of how have things at your institution changed, and how have things changed for you yourself?
Yeah, I think the biggest surprise to me, I mean, maybe it's not a surprise, is how few patients were aware of assistance programs, both for just generalized medical bills and then specifically for transportation costs. I think in our study, we did ask that question. Only 10% of the respondents actually knew of financial assistance programs, and only 3% of patients actually utilize these support services at the institution. So this was one thing that we sort of brought up in thinking about, is there a better way to screen patients when they come into us, at least, especially when they first present? So this is an aspect that we're currently working on, and also potentially, working on expanding this study. And that was why we really focused on, at the end of this study, in our editorial, focused on the ROCR payment program and the heart adjustment, because the heart adjustment, as we found out, is sort of a standardized payment that comes with ROCR for any patient that goes through radiation treatment. One of the things, as we were looking at the background for the study, is that not only is there an issue with screening patients, where screening is very low, utilization is also quite low. So it's two problems, really simultaneously, and that sort of payment program sort of addresses both, because every patient presenting for radiation treatment is screened, and and it's a single question, really. It's, if you have in the past month, I think, have you had difficulty with paying for transportation to your treatments? As long as the patient acknowledges that and responds yes to that question, then those patients will be eligible for the heart adjustment. So that certain amount of money, starting from $500 or more, would be added to their payment model to the institution, and the institution would pay for transportation. So that really sort of helps with the universal screening aspect of it, because if the ROCR does get accepted, does come into practice, then every patient will automatically be screened for that, and it will be fairly distributed. So with our own institution, we do have to work to sort of, in the meantime, set up our own screening program as a result of this study. But I think one of the more important things that I got out of doing this project and is to sort of bring awareness to the ROCR payment model, and to get more support from radiation oncologists for that aspect, for the heart aspect of the ROCR payment model.
Yeah, I know I personally wasn't aware before I read your article that that was, a potential push. But I think as a radiation oncologist, it is very common for transportation to be, whether it's a barrier to the treatment or a barrier to getting the first treatment. You can't kind of get started unless a patient can commit to all their treatments. And, they're oftentimes there may not be the means. I have the privilege of working in the VA system, which has some, just some additional resources for some of those things. But even then, it still can be challenging.
Yeah, that's right. I mean, there have been some smaller studies that look at rideshare programs. I know Medicaid has its own non-emergency medical transportation program, and that's been, pretty heavily studied. As I quoted in the article, about $5 to $6 billion spent yearly. And if you look at the utilization rates for that program, it's still only about 20%, which is, again, quite low. So even though there are existing programs, like you mentioned, through the VA and through Medicaid, in some instances, not all patients within those programs are eligible for that transportation coverage. We have encountered some patients on Medicaid who don't necessarily have the full Medicaid, in which case the transportation is actually not covered, so they're not eligible for that transportation program. So I think definitely to have a more universal program to get pretty much all patients screened and all patients being eligible for this, that's definitely going to make a huge impact for those patients.
Excellent. Well, in our kind of concluding thoughts here, do you have a call to action for those of us, kind of thinking about things in light of being at a big institution, or maybe those of us also kind of in community practice? What kind of plug, based on your review, would you give us?
Yeah, I would say as practitioners, I think, there's a lot that we can do ourselves when we speak to patients, and spending a little bit more time on the cost aspect and the burden to patients financially. I think, if I could I would plug the ROCR program, and hopefully this will garner some more interest from practitioners in looking at what the payment model proposes, both for this and for transportation coverage. I know for those radiation oncologists that are practicing in smaller practices, reimbursement is probably something that crosses their mind very often. And so if this does get accepted by Congress, then this is going to be, again, a huge impact on not on just these larger institutions, but the smaller practices as well. So I think everyone stands to benefit from this, and benefits to know a little bit more for themselves how this is going to affect their practice.
Excellent. Well, thank you so much for reviewing the article and taking the time to advocate for our patients. And reimbursement and potential reimbursement model changes are such a critical component of radiation oncology. So I invite everyone to read the article. It's not too long, so it's worth the read, and you can find it on the CURiE channel on the Cureus platform. So, and Valerie, I think I totally forgot to do this dang disclosures. I told you I would, and then I didn't. So
I
will
forgot.
do it now at the end.
Yeah, you can do them now, and if it's going to be, they can move it to the
You can just move it to the
beginning.
beginning. Okay, yeah, I like as I'm wrapping up, I'm like, I totally didn't say anything about disclosures. So I'm Jessica Schuster, and I'm the current editor of the CURiE channel on the Cureus platform, the ACRO journal. And I will be interviewing Dr. Tony Song and his as an author of our publication. And I and Tony do not have any disclosures related to this article.